Medicos, myself Dr. Krishneshwari and our channel is back again. Today we are going to discuss about the differential diagnosis of headache. In this session we will be discussing about the symptomatology of headache so that it will be easy to differentiate different types of headache in a clinical setting. So in the last session we have discussed about the pathology of headache. Regarding the differential diagnosis, International Headache Society have divided this headache into two: primary headache and other is the secondary headache. So primary headache, in the primary headache, the cause is unknown or there is no secondary cause. In the secondary headache, there will be a specific cause which cause headache. First, we will go to primary headaches. So there are so many varieties of primary headache and we will discuss the symptomatology of each primary headache so that it will be easy for us to differentiate in a clinical setting. So first primary headache we are going to discuss is migraine. So everybody know about migraine. So what is migraine? We know that migraine is a unilateral headache and it is due to trigeminal-vascular dysfunction. So we know that the pain in the head is transmitted by means of trigeminal nerve. So this vascular structures in the head is innervated by trigeminal nerve and if there is any defect in trigeminal-vascular pathways, it leads to migraine. Migraine, it is divided into two. One is common migraine and second is classical migraine. So common migraine is migraine without aura and classical migraine is migraine with aura. And as far as the migraine is concerned, it is a unilateral headache. It is a unilateral headache and it is associated with mostly with autonomic symptoms. So there will be so many symptoms such as aura or photophobia will be there, phonophobia will be there. So migraine is a unilateral headache associated with one or more of the symptoms. Autonomic symptoms are more prominent in migraine. Sometimes the migraine will be associated with aura and sometimes the migraine will not be associated with aura. So this migraine, it is more common in females. So it is said that Harrison said that it is 15% more common in females and Davidson says that it is 20% more common in females than males. And the most important character of migraine is there is a trigger for headache. Trigger may be environmental or sensory triggers. So environmental triggers such as heat exposure or travel, etc. And sensory stimulus such as some smells or some visual disturbance, some noise, light, etc. So these are the triggers of migraine. So we will go to investigations later. So migraine, unilateral headache, triggers will be there, other autonomic symptoms will be there and it is more prominent in females. And also in females, this migraine is more common when there is menses because there is some hormonal relationship along with this migraine. So clinical diagnosis. Regarding the migraine, diagnosis of migraine, clinical diagnosis is the most important diagnosis rather than going for investigation. In investigation, it is very difficult to get something and clinical diagnosis is more important in migraine. So the first primary headache is migraine. Second is tension headache. So what is tension headache? Is it due to any tension or it is a misnomer? So we cannot identify any tension in this tension headache. It is said that there is some tension in the nerves or tension in the muscles leads to tension headache. And this tension headache, the autonomic symptoms are less in case of tension headache and also there will be a sensation of band around the head. Tightness. We will be feeling a sensation of tightness in tension headache as like that there is a band around the head. So autonomic symptoms are there. It is not unilateral. So we can differentiate this migraine from tension headache like this. So autonomic symptoms are rare. There will be tension or feeling of tension or feeling of tight band around the head, and also it is not unilateral usually. Posterolateral, it is said that pain will be felt more in the posterior aspect of the head, and also on the temples. More often it is felt on the posterior aspect of the head. Then third primary headache is cluster headache. So what is cluster is the headache will be coming in bouts. That is, it will be lasting for some days. Then this headache will disappear. Again it will be coming and lasting for some days. Like a cluster, this headache will be coming. And the most common symptom of cluster headache is periodicity. Periodicity means today, if the patient is having headache at 8 a.m. Suppose tomorrow, again the patient will be experiencing headache in that particular time. This is the periodicity. Periodicity is the hallmark of cluster headache. It is also known as alarm clock headache because this cluster headache is more during the night, during sleep. The patient will be awaking from sleep due to this headache. And also the most important symptom is there will be autonomic disturbance along with this cluster headache. Mostly cluster headache is ipsilateral, that is unilateral. Migraine is also unilateral, cluster headache is also unilateral. But what is the difference? What makes the difference? In cluster headache, there will be ipsilateral autonomic symptoms. In migraine, we told that there will be photophobia or phonophobia. It will be affecting both sides of the body. But in case of cluster headache, this autonomic symptoms will be in the ipsilateral. Where the patient is feeling pain, in the same side, autonomic symptoms will be there. It is also known as alarm clock headache, since it is aggravated at night after sleep. And also the patient will be very disturbed during headache. What are the disturbances? They will be rocking their head, they will be rubbing their head, they will be getting so much irritated due to such a intense pain will be there in cluster headache. And the thing is, cluster headache is more common in males. In migraine it is more common in females, but in cluster headache it is more common in males. Then parasympathetic, that is autonomic symptoms are more common. And also next primary headache is chronic daily headache. So first we discussed about migraine, second we discussed about tension headache, third we discussed about cluster headache, next is chronic daily headache. What is chronic daily headache? If the headache lasts for about 15 days or more in a month. In a month, headache should be there for 15 days or more. Then it is known as chronic daily headache. So what are the causes of chronic daily headache? The first and the foremost cause is medication overuse. So suppose a patient experiences headache. So what happens? He will be taking painkillers, that is analgesics for this headache. So what happens? This analgesics, due to the overuse of analgesics, the patient will be experiencing more pain and pain. And the patient will not be knowing that it is due to the use of analgesics. Simply you stop the analgesics and the patient will be free from pain. So medication overuse headache is the most important cause of what? Chronic daily headache. And the second most important cause is low CSF volume headache. In low CSF volume headache, it is a positional headache. The headache will be positional. If the patient is recumbent posture, that is, if the patient is lying, there will not be any headache. And if the patient stands upright from lying or sitting, then there will be increased headache. And the headache will be more in early morning. The headache will be more at night or towards evening hours, and it will be less severe in the morning hours after rising from lying. So this is low CSF volume headache. So the most important cause of headache, chronic daily headache is one is low CSF volume, and next is medication overuse headache. Next, the fifth cause of primary headache is hemicrania continua. Hemicrania continua. Hemicrania means one side of the cranium. Continua means continuous. So there will be continuous hemicranial headache, that is unilateral headache, and sometimes there will be autonomic symptoms or parasympathetic symptoms will be prominent. And in some cases, there will not be any autonomic or parasympathetic symptoms, but the headache will be continuous in one side of the head. And it should be differentiated from what? Continuous headache. It should be differentiated from some space occupying lesions. And also, it should be differentiated from this, as the headache is continuous, you should be differentiated from chronic meningitis and all. And the cause of this hemicrania continua is unknown. Next is primary exertion headache. Sixth cause of primary headache is primary exertion headache. In this primary exertion headache, the headache comes after exertion, either physical or mental exertion, and it should be differentiated from the after exertion. Usually this aneurysm, there is chance of aneurysm breakage and all. So it should be differentiated from headache of intracranial hemorrhage, and also it should be differentiated from headache due to angina. So in some patients, due to this angina, the pain will be extending to one side of the head, and it should be differentiated from angina. And this intracranial hemorrhage is the most important differential diagnosis for primary exertion headache. Next is primary stabbing headache. Everything is primary, so cause is unknown. There is no secondary cause for such headache. Primary stabbing headache. The headache will be stabbing type. So there we can feel that there will be a single stab or continuous stab will be there. The pain will be felt like stabbing, and this primary stabbing headache should be differentiated again from this intracranial hemorrhage as well as brain tumors. And then next is primary cuff headache. So some patient will be experiencing headache after coughing or heavy weightlifting or sneezing. The cause is again unknown. It is primary cuff headache. Next is primary thunderclap headache. So this primary thunderclap headache, they will be feeling severe strong headache will be there, and they will be feeling as if feeling of a thunder clapping in the head. So it is known as primary thunderclap headache. It should be differentiated from other secondary headaches what I have told earlier. Then next is primary sex headache. In this primary sex headache, the patient will be experiencing when there is sexual arousal, and this headache will be reaching its maximum during orgasm. So this is primary sex headache. And the last primary headache is hypnic headache. Hypnic headache is the patient will be experiencing headache after sleep, and this will be lasting for 10 to 30 minutes. So hypnic headache, the patient will be it is different from cluster headache. So in this hypnic headache, patient will be experiencing pain during sleep, and it will be lasting for 10 to 30 minutes. Again the pain will be reducing. The patient will lie down and sleep. Again it will be starting, and it will be lasting for 10 to 30 minutes. So these are the most common, not most common, these are the common causes of primary headache. The most common primary headaches what we are experiencing in day-to-day clinical practice is 1 migraine, 2 tension headache, 3 cluster headache, and rest of the, and also medication overuse headache also we can found in clinical practice. So these are the list of primary headaches without any secondary causes. So I hope that you understand this. Next we will go for secondary headaches. Regarding the secondary headache, there are so many causes of secondary headache. As said earlier, secondary headache, there will be a cause, and the headache is secondary due to this cause. The causes of secondary headache, we will discuss the most important causes of secondary headache. The first stands for infection like meningitis, encephalitis, and also abscess, brain abscess. So we all know that the infection will be associated with fever. So in this case, the infections, the headache due to infections will be associated fever along with acute severe headache. There will be acute severe headache, fever, and also associated with neck stiffness. So acute severe headache, fever, and neck stiffness. And there will be other symptoms like projectile vomiting, mostly projectile vomiting. Sometimes the vomiting will be associated with nausea. So, in case of infection, there will be acute severe headache. It is associated with fever, and also there will be neck stiffness mostly along with projectile vomiting. Then, next is the headache due to another secondary cause of headache is brain tumor. So, mostly 50%, say 50% of patients with brain tumor only will experience headache, and other 50% they will not be experiencing any headache. So mostly the posterior fossa tumor will be having headache with vomiting, and there will be aggravation of headache by exertion and also lifting. Then it may be due to posterior fossa tumor. And the headache is not continuous, the headache is not severe. So the headache will be not severe, it will be dull pain, and it is intermittent type of pain in case of brain tumors. And suppose if this type of headache is associated with galactorrhea or prolactinemia, we should go for diagnosis which pertains to the prolactin secreting tumor of the pituitary. And if a patient with non-cancer, if a patient is having a history of cancer, and if he is saying that he is having this type of headache, then we should go for, the diagnosis should go for the metastasis of this cancer to brain or to the meninges. So brain tumor, it is not acute severe headache, it is intermittent type of headache, and there will be associated symptoms where the tumor is. Then the cause of secondary headache is intracranial hemorrhage. So, in case of intracranial hemorrhage, again the headache will be acute and severe. The headache will be acute, the headache will be severe, then there will be associated neck stiffness. And what differentiates from inflammatory type of headache? There will not be fever in case of this intracranial hemorrhage. So, intracranial hemorrhage, it may be subarachnoid hemorrhage, there will be arteriovenous malformation, and also the other causes of intracranial hemorrhage such as intracerebral hemorrhage also will lead to this type of headache. Next type of secondary headache is headache due to inflammatory cause. Headache due to inflammatory cause accounts to temporal arteritis mostly. So, what is arteritis? Inflammation of the artery. We all know that this temporal artery, it is situated outside the intracranial space. So what happens? The patient will be feeling pain externally, and also there will be tenderness when we are palpating the site. In other causes, there will not be any tenderness. We cannot elicit any tenderness. But in case of temporal arteritis, we can elicit tenderness at the site. And also, this pain is of dull type. Dull type of pain will be there. And if the arteritis is of ophthalmic artery, then what happens? There will be chance of blindness. And also, the most important cause of bilateral blindness above 65 years of age is due to ischemic optic neuropathy due to arteritis. Very important. Bilateral blindness after 60 years of age, it is due to ischemic optic neuropathy due to arteritis. Then the next cause is glaucoma. So everybody know about glaucoma. It is increased intraocular pressure. So what is increased intraocular pressure? What is the normal intraocular pressure? Harrison says the normal limit is within 20 mm of mercury. The normal limit of intraocular pressure is within 20 mm of mercury, and if it rises, then there will be pain. The patient will be experiencing sharp, dull pain in the orbit. There will be sharp, excruciating pain in the orbit, and also the eye will be congested and red in case of glaucoma. So these are the points which help us in differentiating different types of headaches. Then the last and the secondary headache. Secondary headache, it is due to referred pain from the other structures of the head, like ear or throat or cervical area or eyes. So this stands for last cause of secondary headache. So in this class, in this session, we have discussed about different types of headache, starting from primary, ending in secondary, and in this we have differentiated so many types of headache which is of importance in clinical setting. So this is a lengthy video, but I think it is of useful to all of us, including me. So tomorrow or next session, not tomorrow, in the next session we will be discussing about the investigation, and we will keep a full and we will be getting a full view of headache. So regarding investigation, I will be discussing each investigation and how to differentiate different conditions from each investigation. So thank you for your patient listening. Be safe, be healthy, happy learning, keep in touch. Please subscribe, hoping for your further support. Thank you so much.